Hi, everyone. It's Howard Kushner here. Um, I'm going to talk today um, on Tourette syndrome as a diagnostic tool. Um, and I can't see my slides here now. Sorry. Um, Anyhow, I have no external funding for this. I have no internal funding for this. In fact, I do have some internal funding from the Robertson Endowment, which I'm professor of, and the Center for Brain Mind and Behavior at Emory. And I want to also say that I am left-handed, which is um, seems silly right now, but won't be in a minute. Um, I'm trying to get my next slide down if I can. Okay, everyone. So this talk is a talk to look at what we would call lately the applied history of medicine, where the history of medicine historians of medicine collaborate with other researchers um, and raise new questions weren't there before. I think the thing that struck me when I agreed to do this was only that I realized halfway through preparing my slideshow that I was indeed 25 years ago that I wrote my book on Tourette syndrome, the cursing brain, which I assumed um, that you can all see the cover to. And my question as a historian was to myself, was there anything new I learned since then? How well does it hold up? And what can it what can I learn from it that will help me develop answers to some important questions? Most um, startling to me was to realize that two major treatments have emerged since 1980s that are used for Tourette syndrome that didn't exist or wasn't taken seriously 25 years ago. And also, when I started working on Tourette syndrome, it was seen as a rare disorder. And today, it's seen as we'll see in a couple of minutes when we look at the uh, prevalence, it now is seen as pretty high prevalence among young children. So I wonder how we got there and how we got to the second extremely promising, but also uh, somewhat dangerous intervention of trying to fool the circuitry that causes the tics related to Tourette syndrome. And I'll explain this more carefully. So the real question for me was, looking back over this, did the great increase in number of Tourette's diagnoses come as a result of just getting the right diagnoses, or was there an actual increase in the prevalence of Tourette syndrome? I'm also going to look, when I'm done, at how this connects to Kawasaki disease. But I decided as I was preparing this that I would bring to that discussion open to everyone else and brief, so it won't be just my talking to you. So I really want to do this, as I say on my slide here. I want to suggest how the histories of Tourette syndrome provided an exemplar for other elusive syndromes like Kawasaki disease, and in my recent case for stuttering, in terms of innovative treatments for these disorders. Why did I get interested in this in the first place? Well, in the street I lived in San Diego in the 1980s, there was a young man, 12 years old, who would come over all the time and visit my son, who was about the same age, maybe a little bit younger. And he would say things like, he would curse all the time. He had shaking tics, and he blurted out inappropriate phrases all the time. If he saw a black person, he'd use the N-word. He cursed frequently. If he would say the most inappropriate thing possible, if he were flying on an airplane or getting on the plane, he'd scream out, "There's a plane on the plane, there's a plane on the plane." He couldn't control it. Yet initially I did, and so did all the other people around him, think that this was some behavior he could control. But as it turned out, the more I knew, the more I realized that he couldn't control this behavior. And yet he paid a heavy price for it, both socially and in other ways. He had a violent temper once in a while. So he couldn't develop any friendships. He couldn't really work well in school. He couldn't keep his head straight because of the tics moving back and forth all the time. In the early 1980s, though, a group of people from New York City got together who had children with Tourette syndrome and founded an association called the Tourette Syndrome Association. And one of the children that they used to show how uncomfortable and an inavailable treatment was, he was named a guy named Adam Seligman. And Adam became sort of the poster child to show that he had this, but that it was something he couldn't control. In fact, I remember the first time I met Adam where he was giving a talk, is he'd look up and he'd shout out, "Sit down, shut up, sit down, shut up," which was an embarrassment to him, right? But a greater embarrassment to the people around him. By the 1990s, late 1990s, the diagnosis was so widely used, and the number of people diagnosed, children, was so high, that Adam was now sort of an embarrassment himself, because the number of new cases were much milder. And so there was a contest over what this should be kind of as a diagnostic tool. So I started working. I thought, this is really interesting. I had been trained a bit in psychoanalysis. At first, I thought it was a psychoanalytic disorder, but I learned better. And I started to write up grant proposals so I could look at this in historical perspective. And I was hooked up with a group from Brown Hospital at Brown University, Louise Kiesling, Joseph Haller, and Linda Abbott. And I was invited to spend a couple of years working with them, shadowing them, and learning what it was like to see actual patients. Meanwhile, I was also doing the history, trying to see where this was first diagnosed, who diagnosed it, and what its implications were for that. I also spent some time at University of British Columbia under the control and direction of Roger Freeman, who was a pediatric psychiatrist and who was very helpful to open doors for me and for me to be able to view what was going on with the people as opposed to just reading it on the page. The DSM-4, which was 1995, the Diagnostic and Statistical Manual for Diagnosis and Diagnostic Disorders, in 1955, this DSM-4 complex is what you would have to find in order to make a diagnosis. So there's sudden, rapid, recurrent, non-rhythmic motor tics, at least one vocal tic, and the motor tics have to occur frequently, and they have to last for at least a year. There are motor tics, there are vocal tics. There was a lot of distress, obviously. There was onset before the age of 18, and all these things couldn't be the result of a stimulant or post-viral encephalitis. The thing about the TS, Tourette syndrome phenotype, that diagnostic category, it was almost immediately contested when it was revised and set out. So as it was revised, there were real substantive disagreements. There were disputes over the signs, what to include, what not to include, whether obsessive compulsive disorders were a function of Tourette syndrome, whether other kinds of movement disorders were implicated. But it was among the people studying Tourette's across the hospitals in the United States, and Canada, there was a continuing disagreement over what that phenotype should be. And if you can't agree on what the thing is, it's hard to agree on what the cause is. So, so depending on whether or not you included some of these other behaviors like obsessive compulsive disorders, or other kinds of movement disorders, and if they were included in, then the number of cases would be much higher, otherwise be much lower. So the prevalence of TS cases by the end of the 1990s, there are approximately 300,000 children who are diagnosed based on the US Census and the Tourette Syndrome Association, about which I'll tell more. The thing is, with a few years later, the DSM-5, which replaced the DSM-4, had a very different definition, and it included not only obsessive compulsive disorder, but attention hyperactivity disorder, or just ADHD. This matters because to get funded for research on Tourette syndrome, you had to have cases that were, the patients were only Tourette syndrome and had no other comorbidities. So as a result, only 18% of those diagnosed with Tourette's had Tourette's only. So the research was be only on Tourette's, and as a result, we may be identifying an atypical cause, even though it's supposed to be the pure cause. So in short, there was a lot of disagreement over what exactly Tourette syndrome required for a diagnosis, and it kept changing and depending on who made it. And the question was whether it included other comorbidities, which seemed to be there all the time. On the other hand, people would notice that if they got rid of some of the comorbidities in treatment, that the tics were less common. And so all this understanding that there was no real agreement on exactly what Tourette's was, what you should look at to make it what it was a way that I thought, as a historian of medicine, I should look at the history to see how we got to this point where we still, after 100 years or 200 years, didn't know what the it was we were looking at, and yet it was clearly a disease and morbid condition. So I went back to the first definition that came from the work of the Salpêtrière Hospital by Charcot, Jean Charcot. And by looking at the history, I found some very interesting things. First of all, the case that everybody cites from the 1880s, from the 1820s on, of what we later called Tourette syndrome, was based on the behavior of a French marquise, who was Dampierre is where she came from. And she would walk down the street in Paris and scream, "Merde, foutu cochon," which was translated loosely as shit and dirty pig or fucking pig. And so her case was recorded in 1825. It wasn't called Tourette syndrome since he hadn't even been born yet. But Ita, who was very well known for the L'Enfant Sauvage, the Wild Child of Avignon, that in that 1825 article, he had 3 other cases. And the main thing about these cases that separate them was that the belief that the reason they had these symptoms and signs was they were women who hadn't married yet. And once they married, they'd be all right. Right. And so although no one after Ita actually examined, in fact, Ita didn't examine either, just observed the cursing marquise, it was a case that was cited by everyone who wanted to look at this abnormal set of movement disorders. So although she was emblematic of all the cases, right, actually, no one ever actually examined her, except he talked on 1825, and that was probably just, as I said before, observation. And yet the symptoms and signs were based on hers, even though she didn't have it long enough to fit the categorization. She was a woman, not a young boy, and it seemed to be part of a wider set of disorders. But everyone cites the case of the Marquise, even though, as it turns out, no one actually saw her. Charcot Charcot's head of the Salpêtrière and the director of Gilles de la Tourette, that there was one common 19th century observation, was that these patients all seem to have had some sort of rheumatic fever or rheumatic disease before they got their Tourette syndrome. But Charcot rejected that as just anything, just as an observational bias. So in 1885, he instructs Gilles de la Tourette to write up the cases that they had classified as distinct, as a distinct disorder that he wanted to call a disease of the sickly ticks, maladie de la tic. But none of his cases that he put in 1885, none of his cases actually fit any of these phenotypes. So, in fact, immediately the other interns at the Salpêtrière wanted Charcot to reject the very thing that he had asked Gilles de la Tourette to set up. And so by the time we got to 1900, the dominant theory of the Salpêtrière physicians was that this was one form of many forms of compulsive disorders, and it was not a single secret or differential diagnosis for just these signs and symptoms. Two of Charcot's students, Miege and Fendel, in 1902, and then translated into English in 1907, wrote the book that was the most influential in making diagnostic and other kinds of observations about ticks. And they wrote a book called Ticks and Their Treatment. And that became sort of the Bible for everyone until the 1920s. And what they argued was that these people with Tourette syndrome were weak-willed, that they came from a degenerated family, that they had habits that they persisted in, despite the fact that these habits were not wanting to be displayed by the people themselves. So the central person they talk about in this book, Miege and Fendel, was a story of a guy named O. And they said that he was willful, that he was self-indulgent, that he was a whiner. Meanwhile, the O had managed to create a major manufacturing business, had done everything he could to control his tics, was embarrassed by them. But indeed, this story, which began to be now blaming the patient for the disease, became central to the thinking about Tourette syndrome for the next almost 100 years. In the 1930s and 40s, Sandor Ferenczi and his student, Margaret Mahler, wrote a series of articles where they reframed Tourette's illness, right, as a psychiatric disorder. And they claimed that the reason that the kids had these tics was because of their parents' practices toward them and their patients' actions themselves. In fact, their dominant paradigm for understanding it was psychoanalytic, in that they argued that the tics, the movements, were attempts to subsume and restrict desires for masturbation. And therefore, they blame the parents for not controlling their children's masturbation, even though there was no evidence that there was any relation. And in a series of articles, they interviewed some of these patients, two in particular, Pete and Freddie, who finally shouted out one day in the middle of this, trying to get them to say that they were masturbating, or they were repressed masturbating, or they were thinking about masturbating, that Pete said, "This is witchcraft. This is crazy. I just want to get rid of my tics." But in fact, this was the dominant paradigm until the 1950s in the United States. And at the same time, there was another disorder that was sort of running parallel to Tourette syndrome, but wasn't seen as part of it. And that's called Sydenham's chorea, named after Thomas Sydenham in the 17th century. 19th century physicians were reluctant to see each different movement as a different disorder. So they subsumed many of these movement disorders as Sydenham's chorea. And there were variations in movements, symptoms with different manifestations of some common underlying condition. So there was an underlying condition that manifests itself in different ways, but they also saw and separated their tic disease, right, from other movement disorders because it had a prior attack of rheumatic fever. Sydenham's chorea today is still a separate disorder from Tourette syndrome, but the hypothesis of my book was, in fact, they're really the same thing, just a different underlying presentation. And so in Sydenham's chorea was a ceaseless occurrence of a wide variety of jerky, rapid, involuntary, but well-coordinated movements. So they were more well-coordinated, it seemed, than the Tourette syndromes, which seemed to be disordered. Facial movements with frowning, raising eyebrows, pursing lips, smiling, bizarre bilateral movements of the mouth and tongue, and the onset of 5 to 15. Now, they knew what rheumatic fever looked like, but no one understood what it was exactly. And as we uncover more and more of what Sydenham's chorea was, we can see how it meshes more and more with what Tourette syndrome would become. And the onset was generally 5 to 15 years. So there was some connection to an antibody reaction in the circuitry of the brain called the basal ganglia in Sydenham's. If we understand Sydenham's chorea, we may understand something about Tourette syndrome. Toronto and Stollerman in 1956 established a connection between Sydenham's chorea and a prior infection of group A beta hemolytic strep, that's rheumatic strep. In 1976, the basic mechanisms were discovered or identified of antigen-antibody response. That is, if we look at this cartoon for a minute, the caudate, the pumette, the putamen, and the globus pallidus, this circuitry, if interfered with by, let's say, in a brain operation for someone with intractable epilepsy, that they would have all kinds of movement disorders if that circuitry were interfered with in any way. And the assumption is that Sydenham's chorea, for some reason or other, had led to lesions in this area of the brain, which led to the movement disorders and the lack of control of upper cerebral actions. Now, although this was done these studies were done in the 1950s and 1970s, they weren't reconnected back to Tourette syndrome, at least not yet. In the 1960s in France, they began to use chlorpromazine, right, thorazine, or in fact another drug tranquilizer called haloperidol. And this seemed to control the tics. And in the 1960s, Elaine and Arthur Shapiro, who had seen in New York City, who had seen many of these patients, concluded that there was a problem with the receptors in the brain and that organic causes of the tics could be controlled by haloperidol. Haloperidol is still used in hospitals for control of intractable patients in terms of behavior. So this would, although very effective, it had a bad side effect, which is it turned these kids into almost zombies because it was suppressing their movements and dopamine in the substantia nigra circuit. So there was a relief by sets of parents in New York who were supporting Shapiro, who helped fund the Tourette's Association. They were very eager to get their children diagnosed as a result of an organic disorder rather than to see them as a result of repressed psychotropic behaviors and psychoanalytic behaviors, and especially fantasies about causes of tics and the fantasies toward masturbation. So by this time, with the support of New York physicians and some others across the world, and reading the French and German texts, the organic hypothesis was that Tourette syndrome was a result of a hypertransmission of dopamine. In that movement circuit, it was leased in some way that made dopamine transfer faster and out of control of the afflicted person, and that there was hypersensitivity of these receptors and a disturbance in their circuitry. So the evidence for the cross-reaction in Tourette's was both clinical and laboratory. Clinical was that infection with serial infections, actually, with group A hemolytic strep, which is rheumatic strep, were present, and they exacerbated tics, and they, in fact, the whole circuitry, and that these children, if you look at their clinical history, had early treatment, particularly with treatment to their antibodies. The way it worked, it's called molecular mimicry, which is the antibodies to the strep infection. In fact, the dangers of rheumatic fever, right? The antibodies to that would interfere with the circuitry in the basal ganglia, and then recrudescently, serially time, they build up more and more antibodies as they had more and more history of rheumatic fever. And so the antibodies to rheumatic fever, which crossed the blood-brain barrier, right, it created the movement disorder. Now, to find out if that was true in an animal model, Joe Hallett and the people at Brown decided to see if they can make the antibodies to group A strep bind to the caudate nucleus M proteins in rheumatic fever. And they found in these children over time that they would have recrudescent strep infections. So therefore, even aspirin could be under control, could control some of these movements, as would other sorts of interventions to reduce the exposure to the antibodies to strep. There's a trait marker that comes with strep a monoclonal antibody called D817. And it was found in lymphocytes to group A strep and in rheumatic fever and in Sydenham's chorea. So 85% of Tourette's patients and 87% of Sydenham's chorea patients had this antibody, but only 17% of controls, which suggests that the whole hypothesis of exposure to the antibodies to group A strep was statistically significant and required more examination. So Joe Hallett at Brown decided that what he would do was use the animal model of a mouse and infuse it with the antibodies from Tourette syndrome patients with group A strep and interfere with the nuclei of the rats and mice. The result was that you could create experimentally with these animals vocalizations and tics. The vocalizations, they weren't speaking, of course, but they would go quack, quack in laboratory rats, but none in the rats who were infused with normal sera. In other words, it was possible to break down the circuitry by the exposure to the antibodies to group A strep. So stopping the antibodies or stopping rheumatic fever would in fact be a promising way to examine the causes of Tourette syndrome. As a result, people began to work on the assumption that instead of being a psychoanalytic disorder, that these patients had a predisposing group A strep. No one had bothered to ask the kids who were coming in for treatment in the various movement disorder clinics whether or not they had had a recent bout of rheumatic fever, whether it had continuing, ongoing ones. So they found that, there may not be a predisposing gene, but there is a genetic explanation because the amount of antibodies that would attach to the basal ganglia, right, depended on which group A strep strain, and there are 106 strains of group A strep, would cause movement disorders. So although all children were exposed to lots of doses of rheumatic fever in the 1950s, 60s, and 70s, right, only those who had the specific antibody and group A strep, now there's one of those strains, or I think it's tenor rheumatiform, right, and that would explain the differences. So what's genetic is not necessarily group A strep, but the antibody binding, or what we call molecular mimicry. This had important implications for diagnosis. You could test for titers to GBS. You could examine the history of infection. All of a sudden, we had a whole new area of examination for diagnostic treatment. And the implications for intervention were, instead of using heavy-duty haloperidol, which turned these kids into zombies to their own witnessing, they would say that they couldn't tolerate it. And many of these patients who stopped using Haldol ended up being addicted to other sources. A lot turned to alcohol, at that time marijuana. So the antibody hypothesis led to a whole different notion of how we should treat these patients, and one that didn't have any dangerous side effects, smoking being another one that was highly prevalent among Tourette's patients. So you could use prophylactic antibiotics if they had a history of group A strep. You could clean their blood of all the antibodies, something called plasmapheresis. You could use a particular gamma globulin called IVIG which ironically turns out to be central to Kawasaki disease. It also meant you could use prednisone, and something new in the 1990s, which was actually called deep brain stimulation, or DBS. All of these would have the advantage that they would be able to interfere with tics without necessarily, and identifying them and treating them without necessarily putting them on heavy-duty tranquilizers and antipsychotics. This has now been called PANDAS. And PANDAS are this molecular group A strep molecular mimicry paradigm. And so now we have, by the end of this time period, and where we are today, 25 years ago now, it's for me. But now we have interventions that avoid having the really bad side effects of other interventions that are both organic and yet very successful without causing any damage. DBS, on the other hand, is an attempt to fool the circuitry of the basal ganglia. If the basal ganglia causes these movement disorders and movement tics, vocalizations, and inappropriate behavior, if they could be alleviated by fooling the circuitry, which is a series of on-off switches, right, that you could make the basal ganglia think or act as if it were working the way it ought to. Now, this DBS was first developed for Parkinsonian patients and is still used, of course. It has some bad side effects, and it makes a lot of following up important, but it's very effective, dramatically effective. So I have films of these patients, which I can't show, before they had DBS and after, especially these kids at 6 to 14 years of age, but even older, and therefore it avoided antipsychotics, and at the same time created the possibility that the brain would work either by reducing high dopamine, Tourette's, or increasing dopamine transmission in Parkinson's disease. I was giving a talk 25 years ago, no, it's February 1998, so 23 years ago, about my work and on this book, and that I wrote in the year 2000, when a woman named Jane Burns, who was a pediatric infectious disease faculty member and researcher, was in the middle of working on her own work on Kawasaki disease. And she heard my talk, and she asked if I would join their center and use the historical methods that we had been using on looking for one of the first cases of Kawasaki disease, and whether the increase in cases we noticed were the result of ascertainment bias, they just were there and no one saw them, or that there was an actual increase. And that's a whole other story and a whole other talk. But I just wanted to show that these things are related, because using historical analysis can in fact open up other questions that make us rethink then where we are. In fact, if you think about Tourette syndrome, almost all of the treatments that were until the 1980s really blamed the parent, treated, and the patient, and in fact probably did more harm than good. Whereas moving to a whole other way looking at Tourette syndrome in terms of infectious disease, which then got Jane interested in our work. And she's now gone on to become the world's great expert on Kawasaki disease and save so many lives. So that led me to my next project, which was Kawasaki disease, or led her to recruit me to work with them. And it's been quite exciting. And with our UCST group, by 2014, had all these members of our research team. It's a picture of Dr. Kawasaki, Dr. Burns, Dr. Bastian, Dr. Turner, me hiding back there. So in 2000, I began working with Jane and the group, and we published a large number of papers, traveled around the world looking for the first case, which I'll be happy to talk about. And I moved on to left-handedness because I was interested in stuttering. And so it turned out, of course, that the basal ganglia is implicated in stuttering as well. So retraining left-handers, in other words, forcing left-handers to use their right hands, is now seen as one of the etiologies of tics and Tourette syndrome. Discrimination against left-handers has continued to pose a greater health threat from handedness itself. So whenever there's an acceptance of left-handers, there's a more general tolerance and freedom in general, which is the theme of my book in 2017, on the other hand. But my point is not to say that I've written this book or that book, but rather to say that using a wider kind of set of collaborative efforts, you can see things like the mouse experiment or like handedness switching. You can see things by using other and bringing in other areas of research. So no one would have thought when we started on Tourette syndrome that you can understand a movement disorder as a result of an infection, but indeed, today there is much of this kind of work, and so there's a connection through this of not necessarily in the topic, but in methodology. So my conclusions are that from this work, that medical research problems often require collaboration that has to reach against disciplines. In fact, in our first trip as a group to Japan, we had an anthropologist, a historian, an infectious disease, and a rheumatic physician, Jane Burns, and John Bastian, a rheumatic disorder physician. The solutions to medical mysteries often reside outside of medicine, right? For instance, the solutions to Tourette syndrome, it wasn't medicine that did this solution, but rather going back and seeing the connection between Sydenham's chorea and Tourette syndrome, which now seem to be pretty much the same in terms of outcome, if not the same in terms of intervention. Historians of medicine can play a crucial role in these collaborations, but historical craft insists the past continues to change. So as I look back over, and the reason I was willing to think about doing a paper on this topic, as I think back upon it, it is because I could go back to the historical data and understand that just because something's claimed at one point doesn't mean it can be true. In other words, it can be alcohol can control tics, but by putting it in context, we can understand the danger of that and why we should have moved on as we did to look at infectious diseases. Thus, there's no single history of Tourette syndrome, right? But or other where were other historical data. But in fact, there are histories that reveal alternative strategies to solve the problems in the present. And so I leave you with my talk. Thank you.